My special guest today is Professor Ian Olver, who is Director of the Sansom Institute for Health Research at the University of South Australia. Welcome, Professor Olver.
Thank you.
Lovely to see you. How are you? How's life after the Cancer Council?
Well, look, it's very good. I have a job where I can concentrate on cancer research, and I'm also leading a research institute. And so there's a lot of new challenges. It's a very supportive environment, and I can be very productive there.
And you're back home, of course, in Adelaide, yeah?
Well, home was actually Melbourne, but
Yes.
I lived there for 15 years, so it certainly feels like home, very comfortable there.
That's great. You've just written an editorial for us on the reassessment of rare cancers. Why are rare cancers so problematic in terms of finding treatments and diagnosis for a start? Yeah.
Look, the problem has been that the funding has not been available for rare cancers because their impact isn't as great. So a lot of the funding is going to the common cancers, and great strides are being made in breast and bowel cancer, but some of the rarer cancers are missing out, and we haven't actually had much change in the outcomes of them over many decades.
Right.
So we possibly need more funding. We certainly don't want to take funding away from the common cancers because they have a great impact on the community, and I think the strides forward will continue. But one of the good pieces of news is that now we're starting to type tumours depending on their genetic signature rather than what they look like under a microscope. We're starting to see patterns in the common cancers that are replicated in rare cancers. And an example that I like to give is that there's a type of ovarian cancer, which is an uncommon cancer, which is like triple-negative breast cancer. So there was a class of drugs, the PARP inhibitors, that were working in triple-negative breast cancer that have now gone into trial in ovarian cancer. So we may now start being able to borrow from the more common cancers that have similar genetic signatures.
Okay. How does that work at a clinical level? How does a patient walking into a GP surgery, for example, proceed to the next step of diagnosis and treatment if they have, say, ovarian cancer of a particular kind?
Well, I think what happens is that over time it gives you more options for treatment. So you have your standard treatment, and then you possibly have a clinical trial. Eventually, if that comes into practice, you've got two standard treatments and then a clinical trial. So it just builds up the options available.
You've just released the new edition of the Cancer Prevention Manual that you first did 16 years ago. Obviously, 16 years is a long time in medical terms. What are the major updates that you considered when you were putting that out again?
Well, it needed a total rewrite, actually, because so much had changed. It was quite remarkable. And a lot of it was about the evidence that's been collected around the major risk factors for cancer. So 16 years ago, there was no doubt about smoking, as there isn't today. It is still the most important thing we could do about reducing cancer risk to reduce the prevalence of smoking. But there's a lot more now about diet and exercise where the evidence has become quite strong. And we can be more directive there, and so we can identify 5 or 6 particular strategies to talk to people about, not to try and tell them what to do, but to get, these are all modifiable risk factors. And if you had a family history, say, of bowel cancer, you'd want to know about the modifiable factors. You'd want to know about diet and exercise. You'd want to know about reducing alcohol. It mightn't be a great message for you, but it's an option you have to reduce your chance. So we want to make sure that everyone knows about those things and the evidence gets stronger. And yes, processed meats and red meats slightly misinterpreted in the press, but the evidence was that they definitely cause cancer. The misinterpretation was they don't cause it all that often compared to smoking, but the association is as strong.
It did set off a bit of a frenzy, doesn't it? The whole bacon thing.
The bacon thing, exactly.
Does the media do that often? Overblow these kind of things? I mean, a lot of people go, oh my God, they tell me everything causes cancer these days, I'm just going to ignore it all.
Well, that's one of the problems, you see, because everything that comes along is reported that way, and people that don't like a particular report, like Bacon, say, oh, everything causes cancer, I'm just going to go and continue the way I do.
Yep.
And the problem, that, as I see it, is that there are some important things that actually do cause cancer a lot of the time.
Yes.
And then there are the other things that people love to talk about, but they've got very little impact. So, you know, the big example is if you pay attention to smoking, you pay attention to your weight, which is healthy diet and exercise, and reduce your alcohol consumption, and you pay attention to not getting sunburned,
Yes.
a third of cancer deaths roughly will be prevented. So if you spend all that time arguing about whether hair dye or underarm deodorant causes cancer, even if it did in a very small number of cases, it would make very little impact.
Exactly. Now tell us about the Sansom Institute. It's a broad research institute, but does it give you a chance to do stuff that you're particularly interested in?
Well, yes, it does. The Sansom Institute is essentially the research output of the Division of Health Sciences at the University of South Australia.
Yeah.
And as such, there are 23 research groups, and we think about it in themes. So one of the themes is cancer,
Yep.
which does give me a chance to join in. Population health has been very strong there. It was founded, in fact, on pharmacy and physical
Yep.
science. Lloyd Sansom gave his name to the institute. And then we have healthy lifestyles, so we've got allied health physios and dietitians doing research in that area, maternal health people as well, and finally we've got neuroscience and mental health. So it's a broad brush. But very specifically, I've been able to hire a couple of my behavioural scientists from the old days, if you like, and we're concentrating on things like psychological support of cancer patients, survivors, and rural cancer patients.
Terrific. Sounds like you're having fun.
Oh, I'm having a great time. Thanks. Yeah, look, you know, I enjoyed the time at the Cancer Council and the impact we had on public policy, but there's a time for a job, and I didn't think beyond 10 years would be worthwhile, and UniSA offered me a job just about when I wanted it. So
Exactly.
I thought can't
Terrific.
do better than that.
If you were king for a day, what would you immediately do to prevent cancer in Australia, to bring down that, as you say, a third of them are preventable?
Yeah.
What would you do?
Look, I think I'd take smoking. I'd continue to put the price up to force tobacco out of the reach of people, and then once it gets below 5% prevalence, we could probably legislate to have it on prescription or something like that. If you do that too early, it becomes very socially disruptive. But we know price is the strongest motivator,
Yeah.
so increase the tax, and that motivates people to quit. The second thing is to actually tackle diet. So again, it wouldn't hurt to have a tax on sugary drinks. I mean, there are alternatives. The companies that produce the sugary drinks are often now producing diet drinks, so you can change that production. I think that the food labelling is very important to not only allow people to choose between different types of food and know what the fat content and the sugar content is, but of course if you get too many strikes against you, if you don't have enough stars or whatever, then the companies will reformulate, so it feeds into a healthier population. They have healthier choices to make.
Right.
And we have to do something about informing people about the dangers of alcohol, which are well known in terms of liver disease and you know, other social problems, but a lot of people don't know that they can cause cancer, not only liver cancer and head and neck cancer, but now they impact on the very common cancers like breast and bowel. So it's a real social problem and a chance to modify a behaviour that will reduce your risk.
Do you see the tax system as a way of beating the alcohol problem as well, or is that too fraught place to go.
No, I think what we've learnt from other campaigns is you take multiple approaches.
Yeah.
So there may be a role for tax. I think the tax bit initially comes in taxing, the amount of alcohol. It doesn't matter what the product is, you tax it by its alcohol content, because it doesn't matter what you drink, it's the amount of alcohol you consume. So if you had a broad tax base, that would be helpful. But I think we're doing some research with the University of Adelaide as well, and Flinders actually, on an ARC grant, looking into what the likely impact of labelling alcohol products with health messages, and just to see whether that would be a helpful thing to do, or on the other hand it might turn people off. You can't just take it from one product and put it on another. Exactly. So we're doing some of that research to inform policy later on.
What's the piece of research that you're involved with at the moment that's really piqued your interest?
Oh, look, we did a survey, a web-based survey of patients with cancer, their carers, people with chronic disease and some normals. So we have 2,500 people who have filled in detailed quality of life and spiritual wellbeing forms, and we want to now analyse it to look at the differences, to look at perhaps people where we know that interventions will help them, and it's a wealth of information that we've collected. Very generous people have spent 30 or 40 minutes filling in these forms, and now we'll get to understand a little bit about what faces them as they go through cancer and into the survival period.
Fantastic.
And their carers. That's been neglected, but carers can get as anxious and depressed as patients, and it can last long. That's what the current research is showing, so we've got to sort of look after the carers as well.
Exactly. Thanks so much for your time.
My pleasure.
Thanks, Ian.